All right. Um, from here. Okay, so I kind of expected fewer people tonight since you guys are getting ready for your next MFM and histo exam. So we're only going to cover up through the IT fossa. That way can get you guys out of here quick and back to studying for that. And then after your exam, I'll do, the IT and PT fossa together. All right. Hopefully you guys can hear me. Nobody said yes. All right, thank you. Okay, so I'm using a lot of Allie slides, and I noticed that Stacy is too. She did an amazing job, so no reason to reinvent the wheel when it's already good. I did add in a few of my own and a few things that I thought would be helpful. So it's kind of a mixture of stuff. Okay, start with that second lecture on the meninges and whatnot. Okay, so on the first several slides, he went through the different layers of the meninges and the differences between the spinal cord and the brain itself. And really, like Allie did a really good job of just summing it down to what you really need to know. And that is that you have an epidural, a subdural, and a subarachnoid space. And one major difference between the spinal cord and the brain is that in the spinal cord, the epidural space, it's a true space and it contains the internal vertebral venous plexus and fat. However, in the brain, the epidural space is a potential space. And that's where your epidural hematoma comes into play. So I talked a little bit about this last time, but here's where that talk and die syndrome comes up. So a common scenario that you'll see is, you have a skier going down a mountain. He hits a tree and, smacks his head on the tree. But he eventually, gets back up and he seems fine for a while. And then all of a sudden, he's not fine. And he has a massive epidural hematoma and dies. So that's why they refer to this as talk and die syndrome. And that's associated with a rupture of the middle meningeal artery. So you have trauma to the pterion. And, beneath the pterion is this middle meningeal artery, which gets ruptured. The next thing is that in the brain, we have both a meningeal and a periosteal. Yes, the pterion is that H shape. That's right. So in the brain, we have two layers, both a meningeal and a periosteal layer. And it's important to know that the meningeal layer is giving rise to those dural petitions. So things like, the falx cerebri and the falx cerebelli that you talked about. So next we have the subdural space, also a potential space. And subdural hematoma is going to occur because of rupture to the bridging veins. So if you have a scenario where, an elderly person goes outside to check the mail on a day like today when it's slick and they fall going down the steps and, hit their head, then that's going to rupture these bridging veins. And also in infants, shaken baby syndrome. What results from that is also a subdural hematoma. So here you want to think elderly and infants as your common scenario. And then epidural hematoma would be from trauma. And then the next one is a subarachnoid. And within this space, you have the CSF and the circle of Willis, which we'll get to. And often what you'll see here is a rupture of an aneurysm will cause a subarachnoid hematoma. Don't worry about this word right here, Barry. You'll talk more in second year. Dr. Campbell talks about the different types of aneurysms. But, for now, just know that it's rupture of, those cerebral arteries and veins in this space. So rupture of, maybe the arteries of the circle of Willis. And the common presentation you'll see here is the patient comes into the ER and says, doctor, I have the worst headache that I've ever had in my life. The pain's a 10 out of 10 and it's just terrible. So, what you'll see with that is a subarachnoid hematoma. Okay. And then we already walked through, I think, most of this. The only thing that you want to add in is the CT image that corresponds with each type of hematoma. So with an epidural hematoma, you'll see this lenticular or biconvex shape. And then with subdural, it's a crescent shape. And then over here in the subarachnoid hematoma, you have a high attenuation of blood in the fissures and cisterns, so it really lights up over here. So make sure that you know the clinical presentation, what vessels are affected, and then also be able to associate the CT image with the type of hematoma. So you should have some sort of question on the exam that goes along with this chart here. I would expect that. Okay. And then a common lab practical tag is one of these dural partitions. So the dural partitions are infoldings of the dural meningeal layer. So we have the falx cerebri, and that's this one right here, so between the right and the left lobe of the cerebrum, and then a falx cerebelli between the two lobes of the cerebellum. So it would be right down here. And then a tentorium cerebelli sits on top of the cerebellum, and it divides the cerebellum from the occipital lobe or the cerebrum. So I don't know if anyone has been able to remove the skull cap with the dura intact, but if they have, then that's something that you'll probably see tagged on your practical. Okay. So this is just straight from Dr. Chestnut's slides. So we did have a question on the lecture exam about these herniations last year. So he said that this one was just, FYI right now, and you talk about it more in second year, which is true. So I would focus on either this one or this one being on the exam. So a subfalcine herniation occurs when the brain herniates beneath the falx cerebri. So that's that dural partition between the right and left lobe of the cerebral hemisphere. And then the uncal or tentorial herniation, this is of concern because when the brain begins to herniate back here, the basilar artery is constricted, so you're depriving the brain of oxygen. So for now, I would know subfalcine and uncal herniation. Okay. So you want to have an idea about the innervation of the dura. So the anterior cranial fossa is innervated by meningeal branches from cranial nerve V1. So when I say V1, what am I referring to specifically? Right, the trigeminal nerve that can you be right, the ophthalmic branch, so the ophthalmic branch of the trigeminal nerve. And then the middle cranial fossa is going to be innervated by cranial nerve V2, so the maxillary division of the trigeminal. And then your posterior cranial fossa is innervated by cranial nerve 10. So there's this trick that goes, 5 plus 5 equals 10. Hopefully that helps you remember. Okay. Now, this is the circle of Willis, and there's really not a lot I can say to make this easier other than it's mostly memorization. But one thing I did want to point out is, and this was kind of lost on me last year, like I did not realize this, but when you refer to the circle of Willis, you're not referring to all of these arteries. It's actually only a few of them that make up the circle itself. So within the circle of Willis, you have the anterior cerebral, the anterior communicating, the posterior communicating, and the posterior cerebral. So it's literally making a circle here, and yeah, so don't have the misconception that all of this is the circle of Willis. The circle is formed right here, and the reason that is clinically important is because oftentimes you'll get a lot of strokes will occur in this middle cerebral artery, and that's because you don't have any collateral circulation here. So with the arteries of the circle of Willis, you have a backup, but you don't over here. So a lot of times you'll see MCA strokes arising from the middle cerebral artery. So just keep that in mind. And then also a lab practical tag that I think they like is cranial nerve 3 right here. So cranial nerve 3 is located between the posterior cerebral and the superior cerebellar. So I'm not sure if you've taken the brain out yet. Sorry, I haven't looked at your schedule. But when you do, you want to, see how many of these branches that you can identify in the brain, and then see if you can find cranial nerve 3, and if you see two vessels surrounding it, then that's going to be the posterior cerebral and superior cerebellar. And this is clinically important because if you have an aneurysm here, then this nerve is going to be compressed, which, you can imagine if you're pressing on cranial nerve 3, then you're going to have all kinds of neurological deficits, which I'll talk a little bit more about here in coming slides. Okay, yeah, and then I put a star by it here, so you can see it on the brain, cranial nerve 3 popping out between those two vessels. That's all I wanted to say about this slide. Okay. And then make sure that you are familiar with each of these. I sort of think we may have had a question about one of these. So, we talked about bridging veins already, but another important one is these arachnoid granulations, which are going to drain the CSF from the subarachnoid space into your dural sinuses to be recycled. Okay. So, this right here, this just takes some time sitting down and going over it. Okay, so you have a superior sagittal sinus up here along the superior border of the falx cerebri, and then an inferior sagittal sinus running along the inferior border. And then you have this great cerebral vein of Galen right here, which is draining into the straight sinus along with the inferior sagittal sinus. And then these are going to come together to form the confluence of sinuses. So, and she has this one in pink, this may have been one that we were asked about. So the superior sagittal, the straight sinus, and then the occipital sinuses are coming here to form the confluence of sinuses. So I wouldn't say join because it's not draining into it. So the transverse sinus is going to drain the confluence of sinuses. And if I go to the next slide, that might be helpful. Yeah, okay. So here she has a really simple, diagram showing that. So the confluence of sinuses are draining into these paired transverse sinuses. And then you have the sigmoid and the superior and inferior petrosal sinuses draining into the internal jugular vein. And I think what really helped me get this down is, I don't know if you guys know Jade Funk, but last year she found this picture and shared it on our private page. So if you're a little bit confused about what drains where, I think this picture is really great at showing all of them, so you can follow that path. Okay. So he talked a little bit about the danger triangle. So when you dissect the face, you'll see a very large vein known as the facial vein. So easy enough. So this area right here is typically draining into that facial vein. However, it, in theory, can go to the ophthalmic veins and end up over here in the cavernous sinus, which is going to lead you to the brain. And so really the most important thing, not so much the danger triangle, but the most important thing to know are the contents over here. So he had that mnemonic that was oh, tomcat, or you can just remember that it's the nerves to the eyes. So 3, 4, and 6, and then the sensory innervation to the face, V1 and V2, and the internal carotid artery. Or there's that oh, tomcat mnemonic, and you can go this way with it. Okay. And then I think the last big thing from this lecture is that you should know the flow of cerebral spinal fluid. So you're going to move from the lateral ventricles through the interventricular foramen of Monro to the third ventricle through the cerebral aqueduct to the fourth ventricle to the foramen of Luschka and Magendie, which will carry the CSF to the subarachnoid space, where it can be picked up by the arachnoid granulations and then travel back to the superior sagittal sinus. So you just want to, just memorize the order. And so I added this in. So last year, you know how during your practical, they put the images up on the screen. So they put a CT image up showing the ventricles, and I think they tagged the lateral ventricle. So they had an arrow pointing here. And to be honest, I remember being nervous about that because we hadn't really seen a picture like this before. So make sure that you can identify the ventricles on CT in case they ask something like that again. Okay, so let's go through the cranial nerves. And of course, there's like all sorts of mnemonics to remember the names of the cranial nerves. The one that Allie used was Oh, to touch and feel, very good, velvet, all heaven. I think there's like a Harry Potter one. Honestly, like if you study it enough, they're just going to become, second nature. When somebody says cranial nerve 5, you're going to think trigeminal. So I wouldn't worry too much about a mnemonic, but I do really like this one to help you remember if the cranial nerve is motor, sensory, or both. So some say marry money, but my brother says big brains or big, whatever your preference is, matter most. Of course, this is going to correspond. So cranial nerve 1, cranial nerve 2, cranial nerve 3, and so on. Okay, yeah, and then I looked at these, and these are all great. So if you're needing extra help, check out those websites. Okay, so I have in here, so this is the chart that Allie made, and then this is the chart that I made, and we approached it a little bit differently. So in my chart, I gave you the functions of each nerve, and then in her chart, she talked about what happens if there is a lesion to that nerve. So let's go through them, and I'll try to point out, some of the most like high yield stuff. Okay, so cranial nerves 1 and 2 are going to be sensory only. And then, of course, if you have a deficit to 1 or 2, it's going to be loss of vision or smell. Probably not going to be asked about that just because it's too easy. But cranial nerve 3. So first of all, you want to always remember the cranial nerves that are carrying parasympathetic innervation. So cranial nerves 3, 7, 9, and 10. So that's very important. And then cranial nerve 3, if you have a lesion to cranial nerve 3, so we talked about, that aneurysm pinching cranial nerve 3 in the brain. So somebody explain to me why, if you have a cranial nerve 3 lesion, your eye is going to move down and out. Why would that be the case? Yeah, that's correct. Okay, so what 2 other muscles is it not innervating? Superior, yeah, right. Superior oblique and lateral what? Yeah, lateral rectus. And what is the function of the superior oblique? Anybody? So your superior oblique is helping you look down and out. So if cranial nerve 3 isn't working and the muscles innervated by cranial nerve 3 are not working, then your superior rectus, or I'm sorry, your superior oblique and your lateral rectus are going to take over, and the eye is going to look down and out. And of course, your lateral rectus is moving the eye out, so it's helping the superior oblique. So if your lateral rectus and your superior oblique take over, then the eye moves down and out. Does that make sense? And you're going to have an entire lecture on the eye. But the more times you hear it, the more likely you are to remember. Okay. And are you guys familiar with the mnemonic SO4 LR6? So SO4LR6. Have you seen that before? Okay, I got one yes. Okay, right. So that's going to help you remember those two muscles that aren't innervated by the oculomotor nerve. So SO4, superior oblique cranial nerve 4, the trochlear nerve, and LR6, lateral rectus cranial nerve 6, abducens nerve. So that right there should get you some points. Okay. Next we have the trigeminal nerve, and I'll go over that one more here in just a minute. So abducens nerve is just the lateral rectus. So if you have a lesion to the abducens nerve and your lateral rectus is no longer functioning, the medial rectus is going to take over and your eye is going to drift medially. So they call this medial strabismus, or you will also hear it called esotropia. Okay. And okay, so next we have the facial nerve. So the facial nerve is providing sensation to the anterior 2/3 of the tongue, and then it's also providing motor innervation to the muscles of facial expression. And then also, so I don't totally agree with her chart because she has the parasympathetic function under motor. So I tried to make that more clear by making the star red and then so the star means parasympathetic, so putting the parasympathetic function in red. But it also provides parasympathetic innervation to the submandibular, sublingual, and lacrimal glands. And if we have a lesion to the facial nerve, the common clinical correlate associated with that is Bell's palsy. And I'll go over this more later. Okay, so cranial nerve 8, hearing loss. So cranial nerve 9, one that they like to ask about a lot is what is the motor innervation of cranial nerve 9? So cranial nerve 9 is only supplying motor innervation to one muscle, and that's the stylopharyngeus. So I would make sure that you circle or highlight this one or something, because they love to ask about it, because it's unique because it's only supplying one muscle with motor innervation. So I think cranial nerve 9 and stylopharyngeus. Okay. See 10 and 11. If you have a lesion to cranial nerve 11, you get shoulder drop, and then hypoglossal. So I definitely remember this being on the lecture exam. So if you have a lesion to the right hypoglossal nerve, then your tongue is going to deviate towards the side of the lesion. So it's going to deviate to the right if it were a lesion to the right hypoglossal nerve. So if you know that, that's an extremely easy point on the lecture exam. Because of course, they're going to have, patient has a lesion to the right hypoglossal nerve, and like one answer choice is going to be that it deviates to the right, and one answer choice is going to be that it deviates to the left. So you want to think same side. Okay. I talked a little bit about this last time, but this is very high yield. So you have 3 divisions of the trigeminal nerve, and you want to know I was kind of saving getting into that when we go over like Dr. Leo's drawing of the facial nerve, because I think it's easier to see with that drawing. So just yeah, we'll get there. Okay, so standing room only. So you want to know that V1 passes through the superior orbital fissure, V2 is through the foramen rotundum, and then V3 is through the foramen ovale. And yeah, that's really all you need to get from this slide. Okay, and then these are Ali's slides, so make sure they're going to tag the cranial nerves all sorts of ways. So one way they're going to do it is in bodies where the skull cap has been removed and then the brain is taken out. If there's a body that has the nerves intact, like showing them entering the foramina, then they could definitely tag it like this, like wrap a string around one of these and ask you what nerve it is. So they definitely did that last year. And then also they're going to tag the cranial nerves on the brain itself. And so I know one thing that tends to trip people up. So if there was a tag right here, what would you call that? Oh, sorry, my pointer moved away. Right here. Can you guys see where I'm pointing? So not cranial nerve 3, what if, yeah, so okay, so right here, this is the optic chiasm. What if I went back here and I stuck a pin right here? What would you call that? Oh, right here. So you want to make sure you know that if I tag the nerve right here, this is the optic nerve, this is the optic chiasm, and then what do we call this part right here? So this is the optic tract, right? So optic tract, so optic nerve, optic chiasm, where the fibers cross right here in the middle, and then right here is the optic tract. So if they're going to tag the optic nerve, they can really do it in 3 places, and that changes what you call it. So make sure that you're aware of that. Okay. And so this is the chart I made, and this is giving you the actual functions of each nerve. So I think, was it Haley? Yeah, so I split up the trigeminal nerve into each division. So the first and second division is sensory only. So yeah, so if you had a lesion to V1 or V2, it's going to be a sensory deficit. But a lesion to V3 is going to result in a sensory, and or motor deficit. Let's see. Another thing they like to test on is how the tongue is innervated. So the anterior two-thirds of the tongue has a different innervation than the posterior one-third. So supplying the anterior two-thirds of the tongue with general sensation is V3, and then the anterior two-thirds of the tongue taste sensation is from the facial nerve. Okay, and then the posterior one-third is supplied by what? Which cranial nerve gets the posterior one-third of the tongue? So you have one nerve doing general sensation and taste for the posterior one-third. Does anyone remember? Great, good job. Yeah, cranial nerve 9. So I have that, yeah, right here. So sensation and taste to the posterior one-third. And then also don't forget motor from cranial nerve 9 is only to the stylopharyngeus muscle. So I want to say last year on the practical, they tagged the stylopharyngeus, and then they asked for its innervation. So kind of as like a second order question. And then one more thing I wanted to point out that sometimes confuses people. So you remember how the facial nerve travels through the parotid gland? So the facial nerve isn't actually supplying the parotid gland. It's the glossopharyngeal nerve that's doing parasympathetics to the parotid. So another kind of tricky thing to keep in mind. And then don't forget your cranial nerve 12 lesion. If you have a lesion to the right hypoglossal, for example, the tongue's going to deviate to the right side. So hopefully that'll get you an easy point there. Okay. This is a slide I made from boot camp. Okay, so learn the cranial nerves like this. So find a body that's with the brain removed and the nerves are still intact, and learn it like this. And then also there's something called the rule of fours. So if this is helpful at all, you have 4 cranial nerves that are in front of the pons. So obviously cranial nerves 1 and 2 are more anterior in the forebrain, but you have 3 and 4 from the midbrain. So 4 cranial nerves from the midbrain and farther anterior, 4 cranial nerves from the pons, so 5, 6, 7, and 8, and then 4 cranial nerves from the medulla. So the last 4 from the medulla. So rule of fours, if that helps at all. Okay. Now let's get the facial nerve here. Is with which structure? Do you mean like with which like blood vessel, or where it's exiting? Oh, I mean, yes and no. Like, if you know where cranial nerve 7 is, you're gonna know that it's between the pons and the midbrain, but they're not gonna like specifically ask you, does cranial nerve 7 arise from the pons? Does it arise? Or I'm sorry, I meant to say pons and medulla. So cranial nerves 6, 7, 8 are lying right here between the pons and the medulla. They're not going to specifically ask you where it's coming from, but it just helps you remember where to look for it. So if there's some sort of nerve tagged on the pons, you've only got 4 options. Does that make sense? Yeah. Okay. Um, so here is Allie's awesome recreation of Dr. Leo's drawing. Okay, so advice for Dr. Leo, because I'm pretty sure he hasn't taught anything yet. So his slides are very like 1980s, but he's a really great teacher. He's very good at explaining things, and he's very fair on exam questions if you listen to what he's saying. So he does a lot of drawings, and his slides are fairly minimal. So it's really important that when you listen to his lectures that you take really good notes, um, because he might test over things that he's verbally said. So don't think, oh, I can just read what's written on the slide and I'm fine. You need to really listen to what he's saying as well. But he's very good and very fair, so don't worry about that. Just pay attention to what he says. Okay, so cranial nerve 7. So 2 slides. If you know everything on these 2 slides, you'll be more than fine for this lecture. Okay, so let's just kind of walk through this. So each fiber type she has labeled in a different color. So you want to know that cranial nerve 7 starts to exit the brain through the internal auditory meatus, and then it's going to make its final exit through the stylomastoid foramen to give off these different terminal branches. So the terminal branches to the muscles of facial expression are the temporal, zygomatic, buccal, mandibular, and cervical. So that's where your two Zanzibar by motor car comes from. So if you put your hand over your face, I think you had a picture of that. That helps you align approximately where each of these nerves are getting. Oh, and another word of advice. I noticed he made the comment in lecture that he doesn't really care about the muscles of facial expression. Um, don't take that as he doesn't care about it on the lab practical, because they definitely had more than one tag on the facial muscles. So you definitely still, whatever's on your lab practical list involving the muscles of the face, like you want to know all of those very well because they'll still tag them. So I'm not quite sure like what he meant by that, but yeah, they do care about it on the practical. Okay. So next, so you have your sensory fibers, which are carried by the chorda tympani. And that's going to carry taste to the anterior 2/3 of the tongue. And then also parasympathetic fibers to the submandibular ganglion. And then post ganglionic parasympathetics running to both the submandibular and the sublingual glands. And then also hitching a ride is the lingual nerve. So this is a branch of V3. So remember, V3 is the mandibular branch of the trigeminal. So this isn't facial nerve. This is just the lingual nerve from V3 hitching a ride on branches of the facial nerve to get to the tongue to provide general sensation to the anterior 2/3 of the tongue. Don't quote me on this, but I believe chorda tympani is just referring to the sensory itself, and then the parasympathetics are basically hitching a ride with the chorda tympani. But yeah, so important to know here, the difference between taste to the anterior 2/3 of the tongue and general sensation to the anterior 2/3 of the tongue. So general sensation from V3, specifically the lingual nerve, and then taste from the chorda tympani. That's something that they really like to ask about. Okay. So also off the facial nerve, we have the nerve to the stapedius, which is helping to dampen loud noises. And then this last one up here is the greater petrosal nerve. So with this parasympathetic branch, we're actually giving it a name. So within the greater petrosal nerve, what fiber type do you find? Hold on just a second, Amy. So what fiber type is found within the greater petrosal nerve? Right, parasympathetics, and be more specific. Pre or post-ganglionic? Preganglionic. So preganglionic parasympathetic fibers. That's something they can ask you, what are the fiber types within these named nerves? Okay, so then you have postganglionic parasympathetics going to both the palate and the lacrimal gland. And also you have this deep petrosal nerve running with the greater petrosal nerve. And this is carrying sympathetic fibers to the lacrimal gland. And both of these are traveling through the pterygoid canal. Okay, so back to Amy's question. Yeah, so the chorda tympani is a name given for the sensory fibers found within the facial nerve. Does that make sense? And yeah, it is joining the lingual nerve. So remember, the lingual nerve is not from the facial nerve, it's from the mandibular branch of V3. So in blue, she has, nerves not from cranial nerve 7. So it's joining up to hitch a ride with the parasympathetics and the sensory fibers to get to the submandibular ganglion. Okay. I know it's a lot, and it literally blew my mind last year, but the more that you study this, the more you're going to get it. And it's going to take more than one time. It's going to take, I don't know, if you're like me, it's going to take several times. Okay. Now let's go over the lesions here real quickly. Okay, so the two that they like to ask about the most are number 2 and number 3. So number 2 is going to affect all branches of the facial nerve. Okay, so basically you're going to have a lot of deficits. And he talked about what is the clinical problem described by number 2? Like if we were to give this a name, what would we call it? Yeah, Bell's palsy. And then at number 3, you're having all the same symptoms as Bell's palsy, but you're also noticing some hearing loss. So if we have a lesion number 3, what do we call that? Right, acoustic neuroma. And one thing he said, a way that they can trip you up is like if you get a scenario talking about Bell's palsy, they'll mention that the patient is sensitive to loud noises. So what do we call that? What is like the clinical term he talked about when he talked about loud noises? You remember? Right. So because the nerve to the stapedius is involved, they get what's called hyperacusis. So this nerve to the stapedius is not dampening those loud sounds. So they'll complain about being very sensitive to loud noises. And that's still talking about Bell's palsy. But if you have an acoustic neuroma, the patient is going to have hearing loss. So it has nothing to do with just loud noises, it's that they can't hear. So if you, the reason this is important, and they talk about it more in second year, is if you get a patient and the side of their face is drooping, you're like, oh, obviously this is Bell's palsy. If you don't ask them about their hearing and they don't tell you, you could miss an acoustic neuroma, which is more serious because it's a tumor, and that's something that requires surgery and requires a much more in-depth treatment than Bell's palsy would. Whereas you just say, here's some corticosteroids, and hopefully this goes away in a month or two. So make sure you know the difference between lesion 2 and lesion 3. So 4, 5, and 6, the only difference here is whether or not the lingual nerve is involved. So if you have a deficit just to the lingual nerve itself, you're getting loss of sensation to the anterior two-thirds of the tongue. But if you have a lesion here you have a much bigger problem. So not only do you have a loss of sensation to the anterior two-thirds of the tongue, you also have a loss of taste sensation to the anterior two-thirds, and then you're also losing parasympathetics to the submandibular ganglion. And then if you have a lesion before the lingual nerve, then in number 5, general sensation to the anterior two-thirds of the tongue is spared, and you're just hitting the taste and the parasympathetic innervation. And then down here, you're less likely to be asked about this one just because it's easy. So if you have a lesion to the branches of the muscles of facial expression, I mean, it's obvious what's going to happen. Your facial muscles aren't working. So you're just having a deficit in facial expression. Okay, any questions about that? I would start with first just memorize this and then try to understand it, and then once you're to that point, start adding in the lesions. Okay. That's all I've got for you guys tonight. We'll do the IT and PT FOSS so on next week. So I saw Logan posted about your anemia TBL. Like, I just want to make a big plug for the Ninja Nerd video on the different types of anemias. Like, really, all I did to study for that TBL was watch that video. I know it's 30 minutes, but he's really good. So watch that video and then read Michael Ray's study guide. And I think maybe I missed one, but it's a TBL, so who cares? Yeah, so Logan posted Michael Ray's anemia TBL study guide, and then in the comments, I posted the link to the video, to the Ninja Nerd Science video that goes along with it. So if you do both of those things, I think you'll be really good going into the TBL. Yeah. Yeah, and you can double speed YouTube. Like that was not something I ever realized until medical school, but yeah, double speed on YouTube too is a great thing. All right, if you guys don't have any more questions, I'll get out of here. Yeah, you can double speed YouTube if you go to like the little wheel setting thing. I know. I'm glad I'm not the only one that didn't realize this. But it does help.